Hey guys, so this is chapter 94, psychiatric nursing, and it's the new and improved model. So let's get right to it. Okay. Psychiatric nursing, what is it? It's just about mental health nursing, but mental health principles apply to all clients in all settings. People that have physical illnesses can also develop emotional or psychiatric problems that interfere with their recovery and vice versa, right? So as nurses, we have to encourage clients to get counseling to manage stressors or other issues before they become larger concerns. Okay. All right. What is mental health? Okay. According to the World Health Organization, it is, quote, a state of physical and mental well-being, end quote. There are lots of other definitions. It's being responsible for your own behavior, managing your ADLs. In other words, can you take care of yourself? Can you adjust to new situations and handle stress without blowing a gasket? Can you maintain enough energy to be a constructive member of society? Do you have some self-awareness to look into your personal strengths and weaknesses and accept them and maybe try to change them if you can? And are you able to accept frustration and change, because that's going to happen in life a lot, without resorting to harmful, self-defeating, or even dangerous behaviors? So those are all, they all speak to mental health, wellness. So as you can see from our guy here, stress, which includes money worries, job worries, health worries. Oh, it's heavy, heavy. And his coping and defense mechanisms are up here, not balanced. Here, he's got a smile on his face. Everything is balanced. That's what we're aiming towards. You're always going to have stress. You just are. How do you deal with it? How do you cope? Is it healthy or is it not? So speaking of coping mechanisms, let's talk about defense mechanisms. My pal Sigmund Freud, who is the father of psychoanalytic theory, came up with this theory of how individuals use these defense mechanisms to resolve conflict and reduce anxiety, preserve their self-esteem. They're healthy in many ways, but if they're used excessively, then they can be very unhealthy. So let's talk about them. Here's our list. The first two are very similar. In fact, they're almost exactly the same, except suppression is consciously pushing away unwanted thoughts or emotions, and repression is unconsciously blocking those thoughts, memories, feelings, or emotions. Okay? Reaction formation is when a person expresses the opposite of their true feelings or desires in an exaggerated way to hide their anxiety or their shame about it. So when you're in grade school, if a little boy likes a little girl, he will sometimes bully her, take her hat, throw stuff at her. So he's acting the opposite of how he feels. He doesn't want his friends to pick on him or tease him. Rationalization, explaining behaviors, thoughts, or feelings in a way that makes them seem acceptable and reasonable. So of course I failed that class. My teacher hates me. Okay. Displacement is taking negative emotions and redirecting them from the source to something else. You had a bad day at work and your boss gave you a hard time, but instead of yelling back at your boss, you go home and you kick your dog. Denial. Denial is just rejecting reality. It's not just a river in Egypt. Denial. So in other words, if you get bad news from diagnostic tests, then your response would be, no, what do they know? They're idiots. I'm fine. Just deny it. Projection is taking your unacceptable impulse, right, and attributing it to someone else. So if you're a sneaky person, then you're going to immediately accuse someone else of being sneaky. So you're just taking what you have that's unacceptable and going, he's sneaky, right? Sublimation, that's one of my faves. That's where you take something that's socially unacceptable and turn it into something that's acceptable. And the one example I use is the mortician. So you have a person who has this weird, innate desire to be around dead bodies. That's weird. It's unacceptable. But if he's a mortician, we need morticians. Now it's acceptable. Intellectualization is where you use logic and reason to avoid feeling, expressing, or even processing any negative emotions. So you're going through a divorce or a bad breakup, and your response is going to be, 50% of all marriages break up. And it is what it is. They're just facts. That's all it is. Regression is reverting to an earlier stage of development to cope with stress or anxiety. This is something that you'll see a lot in children. So if you have a child that's been potty trained for a while and then something happens, like their mom winds up hospitalized. So now they're stressed out. They can't really verbalize it. So what they'll do is suddenly now they're wetting the bed or wetting their pants. They're regressing to an earlier stage of development and behavior in order to try to cope with what's going on. So make sure you know and understand those. Okay. What does it mean to be mentally ill? Mental illness is not the same as a cognitive or neurocognitive defect. We're not talking about Alzheimer's or dementia. We're talking about mental illness. And mental illness is a difference in degree of behavior. And also, in some cases, it can be detachment from thoughts that are based in reality. Okay. Can be influenced by drugs or alcohol. And you could have a brain tumor, metabolic changes, lots of different things that are organic or physical can cause mental illness symptoms. But mental illness can affect every sphere of a person's life, can affect your physical health, your employment, housing, finances, and your relationships. And remember, when it comes to culture and ethnicity, that can influence beliefs about what's normal and what's not. So, different countries, different cultures have different beliefs, and something that we may consider to be kind of weird to them is normal. So we don't want to just blow them off because they're different than us. Okay. But we do want to deal in fact. So how do we diagnose a mental illness? We can't just take your blood and go, oh, look, schizophrenia. So there's a healthcare team that's neuropsychiatrists, psychiatrists, psychologists, advanced practice nurses that specialize in psychiatry, PAs, techs, et cetera, et cetera. And the emphasis here is on behavior and if there's any neurological or brain injury, okay? But the way we diagnose is through this nice little book called the DSM-5. This is the most recent, the Diagnostic and Statistical Manual of Mental Disorders. So the client would then have an interview with the psychiatrist. The psychiatrist would then, document the symptoms, both subjective and objective, then go to the DSM-5 and look it up. And certain diagnoses will say, if the patient has 3 out of these 5 criteria, then they have OCD or PTSD or whatever it is. That is how we diagnose. It's based on observation, which is objective, and then subjective, which is the client's report of what they're feeling or whatever. The book does specify to mention not elsewhere classified diagnoses. When you look up diagnosis codes, because as physicians and advanced practice nurses have to code things, all because of healthcare insurance, used to be called not otherwise specified, NOS. So sometimes one person's criteria won't meet all of the criteria of one specific disorder. So each of the disorders will have one classification that's called NOS. Now it's called NEC, not elsewhere classified. So even within this manual, there can be these gray areas. So, okay. Now, when we are diagnosing, we have to make sure first that it's not organic. In other words, their mental issues are not a result of something that's medical. Okay. So we have to make sure that we're ruling everything out. We can take their history, their physical exam, lab findings. We'll do a toxicology screen just to make sure that there's nothing organic or substance abuse that's causing this. If we find out that it is indeed functional, that means that there was nothing found that was a causative agent. So it's probably psychiatric. There are some standardized tests. There are lots of standardized tests that can be used. You don't need to know all of them. You do need to know the MMSE, which is the mini mental status exam. And for fun, I'm also going to include the Rorschach ink blot test, which is a very old test. And I got some pictures coming up. So here, this is the Rorschach ink blot test. So you would be shown these pictures of different ink blots. And the psychiatrist would say to you, what's the first thing you see in that ink blot? What do you see? I see 2 people with their mouths open, maybe 2 crocodile people. At any rate, I'm just having fun. Whatever they see first in these ink blots, there's a guide that comes along with the ink blots that gives you some specific answers that can help you determine personality issues, personality disorders. The mini mental status exam, here it is. And this is actually what it is. So there are questions here, and each question is scored And it's scored based on the patient's ability to completely and correctly answer the question. Okay. So the maximum score they can get is 30. If the score is 23 or lower, this will indicate some type of cognitive impairment. Now we're talking something that may be more neurocognitive, like a dementia, because the questions range from what is the year, season, date, day, and month? Where are we? Right? And then you'll give the patient, or you'll tell the patient 3 objects, and you'll name them. And then you'll say to the patient, to repeat them, and then you're going to give them 1 point for each correct answer. The next one is the serial 7s. Honestly, most people cannot successfully complete this one. This is where you instruct the patient to begin at 100 and to count backwards in increments of 7. If they have a hard time doing it, which a lot of people do, you can get them to spell the word world backward, DLROW, right? Then, remember those 3 objects? You're going to ask them to recall those 3 objects that you told them 2 questions ago. And then the last piece of it is you're going to show them a pencil and have them name it. Hopefully they name it correctly. Show them a watch. You're going to ask them to say no ifs, ands, or buts. You're going to see if they can follow a 3-step command. Take a paper in your hand, fold it in half, and put it on the floor. And they have to complete all 3 of those things successfully to get the points for that. You're going to have them read and obey the following. So you're going to show them a thing that says, close your eyes, and they should close their eyes. You're going to ask them to write a sentence, and it needs to be a complete sentence with a noun and a verb, subject, complete, not partial sentence. Then you're going to ask them to copy the little design that's shown here. Okay. It doesn't need to be perfect, but it needs to at least show that these parts are intersecting and how many sides each of the objects has. And then you score it. That's the mini mental status exam. And then we can do neurological tests because in this case, we're probably looking for ischemia, which means lack of oxygenated blood flow. We're maybe looking for tumors, right? So we can do CTs, MRIs, a cerebral angiogram. Whenever you hear angiogram means we are looking at blood flow of arteries. In this case, cerebral, okay? That can show us if there's an impingement of blood flow somewhere in the brain, because that can be a reason for, behavioral changes. You're also doing sleep studies. Sleep deprivation can make people hallucinate and all sorts of things. And we may even do a lumbar puncture just to make sure that there's nothing bacterial or viral, something infectious is not happening. Make sure we can rule that out. So what are the symptoms when we talk about mental illness? So noticeable behavioral changes, maybe responding to people or things that nobody else can see, overusing those defense mechanisms. Suddenly they just don't care about what they look like. They don't bathe. They don't dress appropriately. Inappropriate dress is one of the first signs of mental illness, by the way. So if it's 90 degrees outside and the patient has a parka and a hat and scarf on, problem. They could be not eating at all, or they could be binge eating. They could be not sleeping at all or doing nothing but sleep. And physical symptoms are called somatic symptoms without any identifiable medical cause. Because when you are having mental illness, you sometimes will demonstrate or present with physical symptoms, and we can't find a reason for it. The first thing that comes to mind is a pseudo pregnancy, where they will actually gain weight in their abdomen. It looks like they're pregnant. They believe that they're pregnant. All right. Other symptoms are loss of contact with reality. In other words, altered perceptions, sensory changes, hearing voices, right? Those are hallucinations, auditory hallucinations, being hypervigilant, having delusions, which are concrete thoughts that no matter what proof you give them that it's not true, they don't believe it. Distorted thought processes, difficulty filtering out irrelevant stimuli. So you're having a conversation with the patient and then they're just looking out the window and they just can't filter out the fact that there's a plane going by, even though you're in the middle of a conversation. Sometimes paranoia, the FBI is watching me, which kind of goes hand in hand with the delusional thought. So the FBI can hear my thoughts through my brain. I need aluminum foil on my head. There can be cognitive confusion which is more associated with neurocognitive disorders like dementia, but it can happen. There can be thought blocking. In other words, they'll just not think about a certain thing. Loose associations. Let me give you an example of that. If the patient starts to answer a question that you ask them, and it includes the word, like you ask them, who lives at home with you, and they say, well, it's just my mom and me and my dog, and then they'll go, dog. You know, the dog ate a cat the other day, and cats have 9 lives. So they're kind of associated, like the dog and the cat. They're associated, but very loosely. The point that we were at the beginning of the conversation gets lost, right? Which goes hand in hand with poor abstract thinking and illogical thinking. They can't problem solve. They can't cope with stress. They'll get preoccupied with certain thoughts, sometimes about religion or the end of the world or death. Can't concentrate, poor memory. Sometimes they'll have slow speech or speech aberrations, and they're fun. So things like echolalia and word salad, and we'll talk more about those. Echolalia is where whatever you say, they'll just repeat. Whatever you say, they'll just repeat, just like that. Morbid fascination with death or religious preoccupation, or catatonia, becoming catatonic, where they're not moving. They're not even moving their eyes. They're just still like a statue, and they're mute. They don't speak. Okay. So is the following statement true or false? Cultural factors influence beliefs regarding causation and treatment of disease. And if you said true, you would be right, because it is true. Different cultures have different customs and beliefs. And, you know, things like eye contact and the belief of what causes illness, those are their beliefs. We have to kind of respect them, but we do have to deal with fact. So clinical diagnosis, well, is the problem acute or chronic? Or are the symptoms well controlled, where they had a chronic, condition, but it's been well controlled? You want to get their history, as full a history as you can. And let's move on to the actual disorders. So first we have mood disorders, major depressive disorder, and major depressive episode. And then we have dysthymia, and thymia means mood. So dysthymia means a messed up mood, not working right mood. If you saw euthymia, that would be a normal mood. And then the last one of the mood disorders we're going to talk about is bipolar disorder. And there are different types. There's bipolar 1 and bipolar 2. But so let's talk about major depressive episode and major depressive disorder. Depression, by the way, is the most common mood disorder in this country. Maybe the world, but I'm not sure. Definitely in this country. So what are the symptoms and signs? They get depressed, and they feel depressed almost all the time. They'll have weight and appetite changes. Again, it could be either they won't stop eating or they totally stop eating. Sleep disturbances, psychomotor retardation. They're not much movement, or catatonia, where they're just like a statue, or psychomotor agitation. They're fidgety. Fatigue, loss of energy, low self-esteem, excessive and inappropriate guilt, the diminished ability to think and concentrate, indecisiveness. It'll take an hour to figure out whether to wear the blue shirt or the red shirt. Thought blocking, right? Blocking out certain thoughts, preoccupation with certain things, and recurrent thoughts of death, or even suicidal ideation, which means thinking about, maybe I should just kill myself. And the things that you can observe are sometimes you can't observe them. But when you can, it could be crying. It could be, like I said, inappropriate dress, poor grooming. They look anxious. They'll tell you things like, it's all my fault. Everything that's happened is all my fault. They'll want to isolate themselves. They'll be lonely, irritable. And sometimes they'll have just this whole litany of vague physical complaints. My back hurts, my head hurts, my feet hurt. That's really more mental than physical. And with major depressive disorder and major depressive episode, make sure there's nothing physical or organic, because it could be medication induced. They could be hypothyroid. They could have had a stroke, hit their head, MS, and drugs and alcohol. If they're situationally depressed, that means that something happened that triggered them to be depressed. That's a normal human emotion. There are times where we all get sad. So that's not major depressive disorder. That's not considered to be clinical depression, because it's situational and it usually will get better over time. Older folks, do suffer from depression, sometimes more so than they're willing to admit. And usually it's because of situational stressors. I'm getting older. I can't do the things I used to do. I'm alone all the time, those kinds of things. And they usually will not want to talk about them. You want to ask a lot of open-ended questions to get them to talk. Dysthymia. That means they're kind of feeling crappy, mildly a little bit, but all the time, right? And they can have some of the same symptoms, feeling hopeless, not being able to concentrate. It's not as severe as the others, but it's longer lasting. They're just permanently in this state of like everything sucks. That's dysthymia. And then bipolar disorder used to be called manic depression. And then they changed it to bipolar affective disorder, and now it's just bipolar disorder. And that is swinging from mania to depression. Okay. So either they are, when they're manic, it's euphoric. Oh, everything's great. The world is great. I'm going to paint the house. I'm going to go shopping. They won't sleep. They won't eat. Can be dangerous, right? Grandiosity, intrusiveness. They're distractible. They can sometimes get a little aggressive. And they'll sometimes partake in dangerous activities like using drugs or driving too fast. But then after that mania passes, then they go from being very high to very low. So really severe depression. And the cycling can be different. Some people have a lot of mania with a little normal period and then a little depression. Some people have a little mania with a little normal and then a lot of depression. And that explains the different types of bipolar 1, bipolar 2, etc. So personality disorders, this is something different than mood disorders. Characteristics, so things that people do can become dysfunctional, okay? I'm going to ignore the cognition, but let's talk about affectivity, okay? So that is, we all have affectivity, okay? So we can experience things like being sad, tense, worried, maybe angry, right? Or we can experience joy, happiness, enthusiasm, energy. These people are like the extreme. And these people will have these moods of really high negativity or high positivity, right? And it's funny because the people with the high positive affectivity are more likely to experience feelings of joy and usually correlate negatively with depression, but they do sometimes suffer from mania. Whereas the people with the negative affectivity usually correlates with depression and anxiety, which kind of makes sense. They have problems with interpersonal functioning. Sometimes they can't control their impulses. They'll have really unstable moods, highs, lows, sometimes bizarre behavior, and definitely trouble with relationships. Sometimes they can be paranoid, where they think, somebody's out to get me, everybody's out to get me. Sometimes they can have some schizoid behavior. So it's not schizophrenia, but it's schizoid behavior where they're like detached and like not interested in hanging out with people, with friends, or, and they're kind of flat. They don't really, they're not very happy. They're not very sad. They're just kind of there. Okay. Most personality disorders actually start when the person's a teenager, because that's when your personality is really starting to develop. And people can have more than one type, right? Borderline personality disorder, that's the most fun. So they are very hostile usually. They have pathological personality traits. So they will tear a family up, poor impulse control. They'll engage in self-destructive or self-injurious behavior, self-inflicted wounds, like they can be cutters, right? Suicidal gestures or attempts, unstable moods, poor self-image, self-criticism, lack of values, difficult with intimacy, mistrust, very needy, preoccupied with abandonment, and really bad separation anxiety. They will split staff in a heartbeat. You're the good nurse. She's the bad nurse. Here is a nice little table that gives you those symptoms of borderline personality disorder. They're very difficult to deal with. Probably next to schizophrenics, they are the most difficult to deal with, honestly. So what is the pattern of deviation in a client with a personality disorder? Well, it's their interpersonal functioning. If you said that, you would have been correct. right? They have problems dealing with relationships and other people, right? That's the biggest thing with them. Next, we have anxiety disorders, panic attacks, or generalized anxiety disorder. So the patient experiences intense, and I mean intense fear and anxiety without a real cause. They can be shaking, sweaty, diaphoretic. They could feel like they're being smothered or choking. They can have nausea, chest pain. They really think they're having a heart attack and possibly dying. They believe it. So that's a problem. We usually will use anxiolytic drugs for these people, and we'll get to the meds in a little bit. Well, then we have phobias. Phobias are fun too. They are persistent, excessive, unreasonable, and severe fears of a particular thing or a particular event. And I've listed a few of them. Agoraphobia. They don't want to leave the house because they feel like if they do, they might get in a situation where there's no escape, right? That can be called social anxiety. There's aerophobia or aviophobia, which is fear of flying. Ophidiophobia, fear of snakes. Acrophobia, fear of heights. Zoophobia, fear of animals. Arachnophobia, fear of spiders. And claustrophobia, fear of enclosed spaces. That's a common one. And actually, all of these that I've listed, because there are thousands, believe it or not, of phobias, but I've listed some of the more common ones. Claustrophobia. You get into an elevator and it just makes a little, and everybody's just, right? They don't even want to be in the elevator in the first place. So, and it's not because they ever fell out of an elevator or an elevator crashed. And people that have ophidiophobia, that are scared of snakes, have never been bitten by a snake. It's just this fear and they don't know why, right? No reason for it. Then we have obsessive compulsive disorder. Remember, when you get a question where they talk about repetitive ritualistic behaviors, that is your clue that they're talking about OCD, okay? Which is obsession. That's the obsessive part. Recurrent, persistent, intrusive thoughts or beliefs they can't ignore. And then there's the compulsion, which those are the repetitive ritualistic behaviors. Before I leave the house, I check the lock 6 times. 1, 2, 3. If someone interrupts me, I have to start over. 1, 2, and it's got to be 6 times. Can't be 5, can't be 7. Very compulsive, repetitive, ritualistic behaviors. And there are lots of subtypes. So excoriation disorder and hoarding disorder. Everybody's heard of the TV show Hoarders, right? So that's kind of a subtype of OCD. Excoriation is where they literally will just scratch themselves to rawness everywhere. Then we have eating disorders. Anorexia nervosa, not anorexia. Anorexia nervosa. They look in the mirror and they see somebody that's overweight. They don't really see what they look like. So they will literally starve themselves to death. With anorexia nervosa, they will weigh themselves every minute if you let them. They will measure everything they put in their mouth. If you give them something to drink, they'll take 1 drop and get on the scale. I mean, it's a horrible mental illness because if you let them, they will starve themselves to death. When they get to a certain point of thinness, they start to look skeleton-like, and they will actually start to develop lanugo, which is that very fine body hair all over their body, as a compensatory mechanism because their body has no fat left, and the body's going, hey, something's wrong. We're cold. Grow some hair. So that's what happens. And they need intervention. When you have someone with anorexia nervosa, remember Maslow's pyramid. You have to first take care of the physiological needs. So if they're malnourished and starving, fix that first. Then and only then can you deal with the mental or the psychiatric problem. Then you have bulimia nervosa, which is they're starving themselves, but it doesn't look it because they're eating and then they'll go purge. Stick their finger down their throat to make themselves throw up. The problem with that is all the same problems as anorexia nervosa, but add one more thing. Every time they make themselves vomit, all of the acid from their stomach is going up their esophagus, and it's burning and eroding the interior of the esophagus. So they can wind up with esophageal varices, which are like varicose veins that can burst in the esophagus. They can bleed out of their mouth, just bleed to death. And they wind up with ulcers, ulcerations in the stomach and in the esophagus. So that's very dangerous. And then the same kind of outcome, they will do this until they become skeleton-like and die. And then you have the opposite, binge eating disorder, which is where they're not making themselves throw up, but that's like my 600-pound life. They're just going to eat and 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 eat. Okay. So those are the anxiety disorders. There's one more, which is post-traumatic stress disorder. And post-traumatic stress disorder, that is where someone has been exposed to either seeing someone else as the victim of a horrific event, or they themselves were the victim of a horrific event. Could be a rape, could be a murder, could be so many different things. We used to talk about this as relevant to veterans who had been to war and had seen ungodly things happen to, their friends and their teammates. But it's not just people who've been to war. It can be anyone that's experienced something that the experience was so shocking to their system that they are just traumatized for life because of it. I'm taking a quick break because my phone is ringing. Okay, so again, with PTSD, they can have flashbacks where they're reliving the event over and over again. Insomnia, nightmares, hypervigilance is a big one where, they go into a restaurant, they will never sit with their back to the door. They have to see what's coming. And they'll avoid any stimuli that's associated with the event. Sometimes they can't recall part of it or all of it, and they will isolate themselves, and they're often suicidal or self-injurious. So they will, injure themselves. Very sad type of disorder. Not going to get into the factitious disorders, but these are disorders where they will make something up, but it's really a mental illness. So in other words, Munchausen syndrome. This is where someone will be at the doctor's office every day for physical illness. I have cancer. I know I have cancer. I've got to have cancer. I must have cancer, and can't find anything wrong with them. Even worse than Munchausen is Munchausen by proxy. And it's usually a parent with a child where they will actually make the child sick in order to get attention. Gypsy Rose was a documentary about a similar case where the mother actually made the child ill and convinced her that she was in a wheelchair because she couldn't walk. And it didn't wind up well. I think the child wound up killing the mom. But anyway, sometimes they'll make the child so sick that the parent will actually kill the child, poison them slowly, say with antacid or from a car, antifreeze rather, from a car. That was an actual event that happened a long time ago where the mother was taking little tiny bits of antifreeze and putting it into the kid's soup or drink. And the child was getting sicker and sicker. And they were running every possible test you could think of and could not find anything wrong with the child, but nobody was looking for antifreeze. They weren't doing a toxicology screen, and the child wound up dying. So anyway, these kinds of things, these are factitious disorders where the person is not really physically ill, but they either believe they are, or they'll do it to another person, usually their child, and sometimes really make them physically ill. Then we have the queen mother of the mental disorders, which is the psychoses. A psychosis or psychotic disorder is a thought disorder where the person's ability to distinguish what's real and what's not gets blurred. Okay. And this can be organic. So we'd always rule that out first, but it also can be functional, like with schizophrenia. And the way the DSM-5 classifies the symptoms, hallucinations, which is seeing, feeling, hearing something that's not there. Delusions, those concrete thoughts that you just can't prove otherwise. Disorganized speech, abnormal psychomotor behavior. There's negative symptoms, sometimes impaired cognition, but not usually, and sometimes mania, but not usually. So let's talk about the psychotic disorders. And there are descriptive terms that go along with the psychotic disorders, like you'll see paranoid schizophrenia or, catatonic schizophrenia. There's that word echolalia that I talked about before. That's where the person will repeat the other person's words. But then there's echopraxia, where the person will mimic either another person's actions or the actions of another thing. We were talking about a person who was mimicking the behavior of a dog, down on all fours, barking, kind of just acting like a dog. And these are both, they're included in all of these other descriptive terms and signs of, a psychotic disorder. So with psychotic disorders, we have the hallucinations. So they can be auditory, which they're hearing voices, usually hearing things. Visual, seeing things that aren't there. They can be tactile, which is where they're feeling things that aren't there. Usually with alcohol withdrawal, you will see those patients, I have bugs, there are bugs crawling on me. But of course there aren't. There can even be gustatory hallucinations where they taste something that's not there. Olfactory hallucinations where they smell something that no one else smells. And getting back to the auditory hallucinations with schizophrenics particularly, they can have command auditory hallucinations, which is where they have voices and they don't realize the voices are in their head and the voices are telling them to do things. And it's always important to ask them, are the voices telling you to do something? What are they telling you to do? Because they could be saying, kill the staff, kill the nurse. So you would need to know that. Very important. Okay. Let's see. Then schizophrenia, the positive and the negative symptoms. And you need to know these. The positive symptoms, not that they're good, but they're things that you can observe. Hallucinations, usually auditory, maybe command, but you'll see the patient responding to something and there's nothing there. The delusions, like saying, I'm the Queen of Spain. Bizarre, disorganized behavior. I tell the story of the patient when I worked in Atlantic City in the ER, a PIP. The police brought in a man who was butt naked with aluminum foil wrapped over his head like a hat. And he was running down Pacific Avenue in Atlantic City because he believed the FBI was going into his head and listening to his thoughts. And the other thing is they'll have a blunted or flat affect. They're not happy. They're not sad. They're just kind of there. Those are the positive symptoms. Now, the negative symptoms are ones that you can't really observe, but once you start talking to the patient, they kind of make themselves known. And to remember this, remember the 3 A's. Anhedonia, I have no joy in anything. Alogia, which is poverty of thought or speech, I have nothing to think about and I have nothing to say. And then abolition, I got no ambition. They're not motivated to do anything. So make sure you know the positive and the negative symptoms. Okay. All right. I'm not going to get into schizophrenia spectrum disorder, but I will briefly talk about schizoaffective disorder. So that's really fun because you have all the symptoms and signs of schizophrenia and bipolar disorder. Right? So there's 2 for the price of 1. They're also very difficult to manage because of the fact that they have those psychotic symptoms and also the mood problems. Okay. That's a problem. Okay. Here's another question. Is the following statement true or false? A client cannot have symptoms of more than one mental disorder simultaneously. If you said false, you would be correct because they can have symptoms of several. All right. Dual diagnosis. When you hear someone say this is a dual diagnosis facility, what they're usually talking about is it's dealing with patients who have both a mental illness and a chemical dependency of some sort. Okay. So somebody who's addicted to a drug and also has, major depressive disorder or whatever. Okay. The members of the healthcare team, you have the psychiatrists, the nurses, nurse practitioners. You'll have, different types of therapy there also. Usually you'll see veterans have a lot of these issues and mostly because of PTSD. And then you'll have substance use disorder specialists, medical or surgical specialties, interpreters. By the way, Medicare requires every healthcare facility to have on hand or available a language interpreter or a language interpretation service, whether it's by phone or whatever. So everyone must have that. There are different types of treatment centers. There's outpatient mental health clinics where the patient will go there and then go home. There are inpatient services. There's community-based living, like group homes, those types of things, nursing homes, assisted livings, et cetera, et cetera. Halfway houses, they have workshops, vocational rehab, and those types of things. Partial hospitalization programs where like intensive outpatient, but they'll partially be inpatient. So maybe inpatient for a couple of nights and then, in and out. There's crisis intervention. So PIP, which was one of the places that I worked a long time ago in the emergency room at AC, psychiatric intervention. So that was when somebody was deemed to be a threat to self, others, or property. So in other words, a patient was suicidal, or they were homicidal, or just looking to physically hurt someone, or they were destroying property. So someone got in their truck and tried to drive through the front of your house. The police would typically bring them into PIP. We would be able to contact a judge right then and there. And the psychiatrist who spoke to the patient would then tell the judge, here's what the patient presented as. And the judge would issue an order for a 72-hour involuntary hold, also known as a Baker Act. So we'd be able to commit that patient involuntarily to an inpatient facility for 72 hours for observation and possibly treatment. And getting to the admissions, they can be voluntary. So someone can say, you know what, this is a problem. I haven't gotten out of bed for a week. And they can voluntarily go seek treatment. Then we have those emergency or involuntary holds, right? So there are many different kinds of admissions to inpatient psych units. And they can even be court ordered. So what kind of psychotherapy or psychiatric therapy is available? So psychotherapy can be individual therapy or group therapy. It's usually talking, it's verbal, right? Or it could be art therapy or music therapy or those types of things, pet therapy. But cognitive behavioral therapy, which is behavioral modification, is one of the most common that is used. And that is where we basically are helping the patient to work through whatever their issue is from a cognitive standpoint to try to change up their behaviors. That doesn't work with psychoses. Okay, that's okay for mood disorders, anxiety, depression, those kinds of things, but not for psychoses. And then last but not least, we have ECT, electroconvulsive therapy. And this is where we will sedate the patient and we will actually take electrodes to their head and shock them the same way we shock your heart when we hit you with the paddles. This is kind of shocking your brain. And the whole objective is, if you've ever seen a movie where someone's getting hysterical and someone else comes up and slaps them in the face and says, snap out of it. What we're trying to do is get the brain to snap out of whatever it's going through, usually major depression. And you should know this, make sure you hear this. Side effects, temporary amnesia can be minutes, can be hours after the treatment. Headaches, temporary confusion, nausea, jaw or muscle pain. Those are all potential side effects of ECT. You should know that. The board likes to ask it. Now we get to the meds. Oh, the meds. So first we'll talk about the antipsychotic or psychotropic or neuroleptic meds. These are the ones to treat psychotic problems. And they're divided by first generation or typical, second generation or atypical. Okay. First generation drugs, chlorpromazine, which is Thorazine, haloperidol, Haldol, trifluoperazine, stelazine, and flufenazine, Prolixin. All of these share the same kinds of side effects. Weight gain, sexual dysfunction, elevated blood sugar, the patient can become a diabetic, and extrapyramidal symptoms. That's a big one, okay? All typical antipsychotics can produce this extrapyramidal symptom as a side effect. And what it means is motor dysfunction in the spinal tract that causes motor dysfunction in the extremities or the face. They can have Parkinson-like symptoms, stiffness, tremor, and ataxic or shuffling gait when they walk. They can have acute dystonia, problem with their muscle tone, like spasms of the head and neck. Akathisia, which is like the rocking or restless, okay? Oculogyric crisis, which is an involuntary and usually upward movement of the eyes. And I'm going to show you some pictures in a minute. Tardive dyskinesia can happen. And this is where there's a weird and involuntary movement of the mouth, the tongue, and the face, usually the tongue. And by the way, these symptoms can be irreversible. So it's very important that we identify when they start with a patient immediately so that we can intervene. What's the treatment, you ask? What's the intervention? I'm glad you asked. Benztropine, which is cogentin, and good old Benadryl, diphenhydramine, are the two drugs of choice to both treat all of these extrapyramidal symptoms and possibly prevent them. Sometimes you'll see the doctor order benztropine, 1 milligram, just to be taken along with the antipsychotic to try to prevent EPS from starting. Okay? Here are the pictures I promised you. So this is tardive dyskinesia. This is oculogyric crises. That can look pretty scary, by the way. And here I found this nice little chart that compares akathisias, which are the body movements, versus the tardive dyskinesia. And that can be smacking their lips or moving their lips, or it could be the prong, like that. Any of those things. Okay. All right. Other side effects, big ones, bad ones. Neuroleptic malignant syndrome, NMS. Not common, but it could be fatal. It's a reaction to these antipsychotics. They will get muscular rigidity, very severe, autonomic instability, which means their heart rate, their temperature, their blood pressure will go through the roof. They can come in and out of consciousness. And usually it happens when we ramp up high potency antipsychotics. In other words, high doses too fast. And it typically will happen in males and younger people more commonly. And what's the treatment? The only treatment, stop the drug and just treat the symptoms and wait for it to run its course, to wear off. All right, now we have the second generation antipsychotics. They're also called the atypical antipsychotics. Quetiapine, olanzapine, risperidone, aripiprazole, lorazepam, clozapine, and ziprasidone. Okay. The big ones have the stars next to them, right? So like the quetiapine, the olanzapine, and the risperidone, and also the clozapine. Those are the ones that you'll probably get asked about. Okay. I'll put 1 star next to the Abilify, which is the aripiprazole, maybe, but definitely, these are possible. With these, the second generations, less chance for EPS, right? Still can get it, but less of a chance. Still can get weight gain, sexual dysfunction, type 2 diabetes. Okay, so basically the same side effects, but just less of a risk. Then we have mood stabilizers. We're just going to go over 2 of them. One is valproic acid, Depakote, Depakane. It's really an anti-seizure drug, but it's used mostly for bipolar with mania, so mostly manic. No, your serum drug level is 50 to 100. Side effects, this is the big one. Suicidal ideation, it messes with the liver, hepatic impairment, and weight gain. Okay, no, just that. And then lithium, old drug, used primarily for mania. Therapeutic serum drug level of this one is 0.8 to 1.2. Now, this is important. The body views lithium as sodium. So do not, I repeat, not restrict salt intake, because this will increase the risk for toxicity. Signs of toxicity, the early signs are the same as all the others. GI upset, like nausea, vomiting, anorexia. But progressing to ataxia, like these weird movements, tremors, have slurred speech, like they're drunk. Seizures, if we don't intervene, they can go into a coma and die. So make sure you know that about lithium. Okay, now the antidepressant drugs. The ones I highlighted in purple are the ones that you may see on the boards, okay? So for the antidepressants, you've got several subclassifications. SSRIs, selective serotonin reuptake inhibitors, fluoxetine, Prozac, escitalopram, Lexapro, paroxetine, Paxil, sertraline, Zoloft, citalopram, Celexa. Side effects for all of these are weight gain, insomnia, sexual dysfunction. They're the big ones. SNRIs, selective norepinephrine reuptake inhibitors, duloxetine, which is Cymbalta, and venlafaxine, Effexor. Side effects, xerostomia, insomnia, and agitation. And then you have your DNRIs, which are dopamine and norepinephrine reuptake inhibitors. The one you need to know, make sure you know this one, bupropion. It's Wellbutrin, but it's called Zyban when it's used for smoking cessation. So it's given to patients to help them quit smoking. Side effects include xerostomia, headache, hyperhidrosis, which is a lot of sweating, okay? You have your tricyclic antidepressants, your TCAs, and the one you need to know that you're probably going to get asked about is amitriptyline. Side effects include xerostomia, urinary retention, blurred vision, headaches, and weight gain. And then your last one is your MAOIs, monoamine oxidase inhibitors, and the one you need to know is phenelzine. For these drugs, well, this particular drug, for any MAOI, the patient must limit tyramine in their diet because it can cause a hypertensive crisis. Side effects include suicidal ideation, headaches, tremors, dizziness, xerostomia, sexual dysfunction, weight gain, nausea, drowsiness, and hypertensive crisis, which is life-threatening, hypertension, tachycardia, and pyrexia, high fever. And where do we find tyramine? It's found in foods like aged meats and dried meats like pepperoni and beef jerky, aged cheeses, beer, red wine, avocados, soy sauce, and sauerkraut. Make sure you know that. They like to ask about MAOIs, okay? Oh, and with the amitriptyline, it is also used not just as an antidepressant. I'm going to add this. It's also used to treat post-herpetic neuralgia and trigeminal neuralgia. Okay. Post-herpetic neuralgia is pain after shingles. Hurts. It'll hurt for life. And trigeminal neuralgia, the trigeminal nerve, is a damage to that nerve that causes a lot of pain and discomfort. So amitriptyline is often used to treat those types of pain, neuropain, nerve pain, in an effort to avoid opioids, because we all know there's kind of an opioid crisis going on. Serotonin syndrome is a side effect of those selective serotonin reuptake inhibitors, and some other drugs too. So serotonin syndrome is hypothermia, high fever, altered mental status, right? They'll get hyperreflexia, myoclonus, like twitching, tachycardia. They can lose consciousness, and they can lose control of their bowel and bladder. Serotonin syndrome is caused by taking too much of a drug that inhibits the reuptake of serotonin and puts too much serotonin in the bloodstream. So if the patient is told that they're going to stop this one SSRI and start a new one, there has to be a 14-day window where they stop the one drug and then start the other. Oftentimes patients get afraid. They don't want to stop the one completely, so they'll start the new one and still take the old one. Too much, they wind up with serotonin syndrome. It can be very dangerous. Also, there are some herbals that I need to add here. So herbals that you should never take, right? Never take with antidepressants or with SSRIs or all antidepressants, really. And they are ginseng, valerian root, St. John's wort. I'm trying to think if there are any others. They're the big ones. They are used, those herbals, for anxiety and that type of thing. So oftentimes the patients will be taking an herbal and a prescription antidepressant, and they'll wind up with serotonin syndrome. So I'm going to put this here. Never, 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 never take those. Always ask your patient about anything they're taking over the counters, herbals, supplements, everything. And for serotonin syndrome, what's the treatment? There isn't one. We treat the symptoms, get the fever down, get the blood pressure and the heart rate down, and just wait it out until the serotonin levels start to drop. Okay, then the symptoms will subside. All right, then we have anxiolytics. Anxiolytics are anti-anxiety drugs. The big one is the benzodiazepine classification. They are addictive, okay? And in that classification, we have alprazolam, diazepam and lorazepam, Xanax, Valium, and Ativan. They're anxiolytics. They show you out. They can make you dizzy. They can make you sleepy. They can cause some confusion also. And they are big, big, big drugs of addiction. They have big addictive properties. If a patient were to overdose on a benzo, the antidote for a benzodiazepine overdose is flumazenil. Make sure you know that. Okay? Make sure you know that. And then there's one other anxiolytic, and it's called buspirone or Buspar. It's not a benzo. It's in a classification kind of all by itself. It has side effects of dizziness, xerostomia, headache. And even though it's not really a serotonin reuptake inhibitor, it can cause serotonin syndrome if they take Buspar with an antidepressant. Okay? So know that. Then we have the sedatives, tranquilizers, calm yourself down. Phenobarbital is the big one. It's really an anti-seizure medication, but it's also used as a tranquilizer. The side effects include, and you should know, DRESS syndrome. That stands for drug reaction with eosinophilia and systemic symptoms. They also call it multi-organ hypersensitivity. And it's just a reaction that happens that affects all your organs, and you get symptoms like dyspnea, you get short of breath, you'll wheeze, pyrexia, high fever, lymphadenopathy, usually cervical, lymph nodes will get swollen, nausea and vomiting, facial edema, pruritus, itching, hives, jaundice, and your urine can be very dark and concentrated. Okay, so, and you need to stop the drug immediately with DRESS syndrome. Okay, I'm going to add that in here. Stop the drug. Okay. And then we have our hypnotics. These are really fun, okay? Hypnotics are sleeping pills. So the big players are zolpidem, isopiclium, temazepam, Ambien, Lunesta, and Restoril. So Ambien and Lunesta are similar drugs. Their side effects are similar too. They can include vertigo, muscle pain, hallucinations, depression, suicidal ideation, feeling hungover, a metallic taste in the mouth. And here's the fun thing. These both share this possibility of complex sleep behaviors. What that means, somnambulism, sleepwalking, sleep talking, sleep eating, sleep driving. Yes, all true. There are documented cases, lots, and also really vivid and scary nightmares. So I'm not a big fan of these two classifications, especially in the elderly. Okay. And then the third one, which is a benzo, temazepam, it's called Restoril. See how it's Restoril? Side effects, the same as benzos, right? Potential for addiction. It can cause delirium and paranoia and suicidal ideation. It can cause dizziness. And if it's stopped abruptly, if they've been taking it for 3 months or more and they just stop taking it, they can actually have seizures, like withdrawal seizures, and they can die. So every drug has its price, if you will. Okay. Is the following statement true or false? A nurse should give a client attention for positive behaviors. If you said true, then you were right. Yeah. You want to reinforce the good stuff and try to, not reinforce the bad stuff. So when a client's in an inpatient setting, we want to make sure that we're preserving their rights. Okay. Confidentiality, et cetera, treating them the right way. But if there are behaviors that put them or other patients or the staff at risk for harm, then there are last ditch efforts that can provide safety. And these should be last resort. Like you've tried everything else and this is all that's left. And they are seclusion and restraints. Seclusion is isolating a patient. So putting them in a room alone, there's no one there, they can't talk to anyone, and they cannot leave. So there's got to be good reason. There has to be plenty of robust documentation to justify this, okay? And the patient has to either be monitored, maybe there's a camera system where you're monitoring the patient, or you have to go in at least every 30 minutes and make sure the patient's okay. And then we have restraints. Now, restraints can be physical or they can be chemical. Physical restraints, wrist restraints, where we actually tie the patient down. Lap buddy, which is a euphemistic, cutesy little name for this thing that goes over the patient's lap and keeps them in their seat. They can't get up. Mittens. Sometimes you'll see mittens on old folks' hands so they can't pull out their IVs or feeding tubes or whatever. And full rails are considered a restraint. Half rails are not, but full rails are. So you cannot pull all 4 rails up on a bed. That is considered a restraint. Chemical restraints, that's giving someone a medication to restrain them. The medication is not fixing a problem or a symptom. It's used specifically to control their behavior. Okay. We use things like benzos, sedatives, and hypnotics, and sometimes antipsychotics. But with both of these types of restraints, you need some very specific documentation. So if they're physically restrained, they have to have a neurovascular checks done every 15 minutes, and they have to be documented to make sure that there's not skin breakdown or impingement or any vascular. We're not cutting off their circulation. Okay. Documentation has to have an explanation as to every other intervention that was implemented, and that this was the last resort, and this was in the best interest of the safety of the client, the staff, and or the clients on the unit. The restraints have to be released every 2 hours. Okay. And just remember, if they have wrist restraints, you're going to release one and leave that open for a few, and then put that one back on, and then release the other. Don't release both at once. You're asking for a scene. Never tie a restraint to a movable part of the bed, like the rail, because this can result in really serious injury. And there has to be a written physician's order in place. It can't be a verbal over the phone. The doctor or the physician's assistant or nurse practitioner has to have been there and seen the patient and write the order or type the order. And they're only good for 24 hours. Okay. So they have to be re-upped. There has to be another evaluation and another physician's order. I wrote here some of the acronyms and the abbreviations that are used. Some of them are legit. W/D is not an acceptable abbreviation, but it can mean withdrawal. ETOH means alcohol, but you're not allowed to use it anymore. So even though these are in the textbook, I'm just telling you these are not acceptable, but you still may see them once in a while. Okay. The nurse's job, physical care, emotional support, counselor, right, et cetera, et cetera. You're going to go look for them if they escape, maybe. Let's talk about suicide. Here's your must-know points about suicide. Suicidal ideation is having pervasive thoughts. In other words, thoughts that won't go away about your death, about your own death. If the patient admits to thinking or considering suicide, the next question should always be, do you have a plan? And never, ever, ever leave someone alone, not even for a moment, if they have suicidal ideation and a plan, because you may come back and they may be dead. An intervention that works, and yes, this is real, it's called a suicide contract. It's also called a no harm agreement. And basically what it is you just write up this agreement, this contract, if you will, between yourself and the patient, where the patient promises not to injure themselves or try to commit suicide for a specified period, like for the next 24 hours. And then you in turn give them something, an extra smoke break or a visitation from a family, something, right? And they do work, right? And that the board will ask about a suicide contract, I promise. And also just know this for your own benefit, that clients that don't have a support system, if they have substance use disorder history, if they've ever tried to commit suicide, when they have chronic illnesses that are usually progressive and degenerative, or psychiatric diagnoses, these people have poorer prognoses, and they usually will require additional monitoring, sometimes one-on-one, right? Not to be left alone. So here are nursing actions for specific behaviors. If the patient's suicidal, one-on-one, do they have a plan? Make a contract. The patient's hypomanic or manic, give them finger foods, because they're going to not want to eat and they're going to be moving around, burning calories. Chicken fingers, chicken strips, right? So this way they can move around and still eat something. If they're hostile or combative, de-escalation techniques. If they have delusions, don't argue with them. If they have hallucinations, give them headphones that can drown the voices out. Never say the hallucinations aren't real. You say, I don't see that, hear that, whatever, but it must be scary for you. If they're withdrawn, depressed even, try to get them to participate in group therapy. If they're really depressed, always assess for suicidal ideation or sometimes just suicidal behaviors. If someone is giving away prized possessions, like I've had this antique book collection my whole life, And now suddenly I'm like, here, you take it. Or they say things like, I don't matter, nothing matters. Or they suddenly become super happy, super elated. That can mean that they have actually in their head resolved their issue and said, yeah, I'm gonna kill myself. Problem solved. Okay. So beware of that. That is a common thing. Okay. The nursing process, you always have to assess before you can diagnose, then you can plan, then you can implement, and then you evaluate. Did it work? And is the following statement true or false? It's important for the mental health nurse to know medical stuff as well as advanced mental health techniques. Yes, that's true. They usually don't, but they should. And on that note, I'm going to close this lecture out. That was pretty comprehensive. And until next time, substance abuse. Peace out, guys. See you later.